Welcome to our reopening webinar. We're going to cover a few topics today in process, protocols, and safety that really resulted from a number of frequently asked questions from our community. My name is Rob Clark, and I'm the Provost and Senior Vice President of Research here at the University of Rochester. And we've broken this into a few sections. I'll start with some introductions from our expert panel here, and then we'll proceed with some of our experiences at the University of Rochester Medical Center. We'll follow that with some questions related to our reopening plan for the campus, buildings in particular. We'll talk a little bit in the next section about health and safety and PPE and the science, current research that's underway. We'll move from there to some questions around ventilation in the buildings and how that impacts what we do. We'll talk about cleaning in some of the areas that are important relative to transitions for classes and daily cleaning. And we'll talk about some of the areas of suspected or confirmed cases and how things will be handled. And then we'll finish with a discussion on PPE and distancing and student and community conduct as a whole and how we work together. So with that, I'd like to have our panelists introduce themselves and give a little background on their expertise. So perhaps we'll just, we'll start with Pat Beaumont.
Hi, I'm Pat Beaumont from University Facilities and Services. And my role most recently has changed in that my position has been 100% COVID and making sure that University Facilities and Services has the River Campus ready for operation when the students come back, and that we are taking the health considerations of this faculty and staff into our guidance as we move forward. Thanks.
I'm Dr. Michael Apostolakos. I'm the Chief Medical Officer for the University of Rochester Medical Center. I've been leading the clinical response for our hospital and our affiliates to the COVID pandemic for the last 4 months.
I'm Dr. Brenda Tesini. I'm the Associate Hospital Epidemiologist at the Medical Center and an infectious disease physician. And my role too has shifted into primarily managing the COVID response part of the team that's developed our infection prevention policies and procedures.
And I'm Mike Chihoski. I'm the Senior Associate Vice President for University Facilities and Services. And I joined University of Rochester in the midst of all of this. So I've been thrown right into it and have been participating actively in the CURT reopening plans, as well as focused on the facility services requirements around the academic support and residential buildings throughout all of the campuses.
Well, I want to thank all of you for taking time to spend with me today and to help us answer some of the community questions. I know this is a great time of uncertainty for people, and there are many questions that have evolved, and we've really collected a number of them that have been asked repeatedly. And so I think you'll be able to help our community understand a bit more about our preparation today. I thought we'd start with discussion on some of the experiences at the University of Rochester Medical Center, and perhaps Dr. Apostolakos, you could give us a bit of an overview of some of the URMC experience thus far with the pandemic and how things have evolved.
Thank you. Yeah, it's been a long 4 months. It's hard to believe it was just the second week in March that Rochester had our first patient that was known with COVID. COVID probably was in the area before then, but was first diagnosed in mid-March. From that point on, we have had quite the experience and not only learned how to treat patients with COVID, but learned better how to protect faculty, staff, and our patients from transmission. As I said, in March, we saw our first patient. Our entire medical center and affiliates at peak had about 100 patients that were in the hospital. Currently, that's down to about 20. Of those 100 patients that were admitted to our facilities, about half were on the ventilator, on life support. Now we have less than 5 on the ventilator. The amount of COVID circulating in the area is fairly low at this point, and we hope it stays that way. Initially, before we realized how prevalent it was in our community back in March, we did have some transmission in the hospital to staff members as well as patients. However, we rapidly changed our PPE and how we protected ourselves in March. And by March 31st, we went with universal masking. And if one thing changed the transmission, it's been universal masking for every caregiver that cares for patients in the hospital. Since March 31st, it's been very rare that any COVID transmission has occurred in the hospital. And actually, our PPE process has made it quite safe, actually, to be in the hospital. We now have antibody testing, which shows how many people have had COVID in the area. And in the community, the spread is about 4.8% of all patients or all community members have been infected with COVID. Whereas for our healthcare workers, including our frontline workers that work with COVID patients every day, it's 2.8%, showing quite clearly that we've learned how to protect ourselves. And of the staff members and faculty that have developed COVID, that we can tell where they got it from, the majority occurred in the community, not in the hospital. So we feel very comfortable that with what we've learned, we can protect ourselves and not spread the virus to patients, to other faculty, or to staff members.
Thank you. That's very comforting, I think. And the trends on wearing the masks are pretty obvious. I mean, that's been a big factor. Dr. Tesini, what are the confirmed health guidelines right now?
In terms of public health guidance, I think there are probably 3 guiding principles that really rise to the forefront of informing how we conduct ourselves at work, at home, and in our communities. And those would be what we know as social distancing or physical distancing. So really being aware of who you're around and your proximity to other people is trying to maintain around that 6 feet of distance whenever at all possible from other people who aren't already in your household. The other basic principle would be masking, just as Dr. Apostolakos highlighted, has been so successful for us here in the clinical setting and is tremendously successful in the community and other workplace settings as well. There was a study that showed that 2 hairstylists who had COVID infection and had over 100 clients between them, everyone was masking and there was no spread of infection from the hairstylist to their clients. And that's a pretty intimate interaction where you can't maintain 6 feet of distance. So those are really the 2 most important things. Another very important thing to do is wash your hands as frequently as possible and keep up those general tenets of good hand hygiene.
And those are all things we're pretty capable of doing on our own. So
yeah.
Thank you. How are you monitoring the situation in our region currently?
Yeah, we've been in close collaboration with the county health department and Dr. Mendoza almost on a daily basis. We look at the numbers with Dr. Mendoza as well as our friends at Rochester Regional Health. We monitor daily how many patients in our region have developed COVID and how many are admitted. And over the last probably 6 or 8 weeks, we've had a pretty steady number of about 30 patients in our region developing COVID. Most are not requiring admission at this point. And as I said earlier, we have about 20 admitted patients in our region total with COVID right now. And that's been a pretty constant number for the last couple of months.
Can Can one of you maybe discuss the testing we're using? I mean, there's been a lot of debate around testing and the types of tests used, and maybe if you could highlight which test we are using and why we're using that particular one as opposed to others.
Sure, I can start with that. The two basic categories of testing for the COVID disease or the coronavirus infection would break down into a test that looks for the actual virus. So those are usually by a PCR method. You might hear about the nasal swab, throat swab, anything that involves a swab of usually somewhere in your respiratory tract, different secretions. And that looks for actual acute infection. The other type of test that Dr. Apostolakos mentioned is an antibody test, and that looks for past infection. So that's good to use at a community level to kind of understand how many people have likely already had the infection or been exposed to the virus. The main test that we use, that you want to use to diagnose infection though, would be one of these swab tests by a PCR or nucleic acid detection method. And that's what we've been using to diagnose infections. We really have a world-class clinical microbiology lab here at the medical center, and they've been able to develop their own test and resource and advocate to get testing supplies for a variety of commercial platforms that use this test. The main one we're using has really the highest sensitivity out there on the market, so it can detect very low levels of virus from a deep nasal to the back of your throat swab. So that's our preferred test to use.
Great, thank you.
And I would just like to add on to Dr. Tesini in that you will read about a lot of different tests with a lot of different promise all the time. Almost daily we read something new. Our lab is world-class and is using testing that's state-of-the-art, that is able to diagnose COVID if it's there. And we're up to date with all the different other techniques that are being looked at, but nothing other than RT-PCR, the type of testing we're using, has been shown to be effective in diagnosing this virus.
Good, glad we're following good science. So let's talk a little bit about some of our campus buildings. Maybe Mike or Pat, one of you could overview the procedures that we're taking for the reopening and planned reopening of some of the buildings on our campus.
Sure, I'll take that one. So first off, we've assessed all of our residential, our academic, and our support buildings across the campus. Those assessments followed guidance that was established by the CDC. We went through and we looked at all of our mechanical systems, focusing on air, but we also looked at water. Even though COVID's not waterborne, we recognize that a lot of these buildings have been either closed or been underutilized because of the reduction in staff. So we wanted to ensure there weren't waterborne pathogens or other issues that arise separate from COVID. So we've looked at them comprehensively from that area. We've then went out and we've installed a lot of new hand hygiene stations throughout. We've put other safety precautions in place, physical barriers. We've added a lot of signage. You'll see signage all over the campus, reminding you of the safety precautions that are required when you're back here. And we've updated our cleaning procedures that Pat will talk about a little bit in more detail. And we've been working both with the CURT and the EOC groups on campus to ensure that our procedures are continuously updated as new information becomes available.
And just for the audience, CURT is the Coronavirus University Restart team. So there's a team of experts from across the campus who've been working together to think about that. So we just share that with the audience a bit. What specific plans are in place for reopening buildings? I know that since March, we closed a number of buildings down because we shut the campus down effectively. So how are we going to do the reopening?
So as we've talked about, we're doing all of those things as part of our assessment for each building. We've created a checklist. We're validating that each item gets addressed. We've put together a master schedule. We've worked with all of the colleges to determine a priority system for which buildings will open first and in what order. So I'm happy to say we've already opened all of the research buildings. We're now focused on the academic buildings and the quarantine space. All of those will be open by August 1st. And then the residential and support buildings will be open by August 10th. So by August 10th, the entire campus will be back, all of the campuses will be back open and ready to receive students and faculty.
Thanks, Mike. That's great. How about cleaning protocols? How are they going to be different from the kinds of things we've done before in cleaning the buildings and maintaining them?
Sure. So in addition to the normal cleaning process that we have in place, we'll be using EPA-approved products for disinfecting frequently touched surfaces 1 to 2 times per day, depending on the location. We will be paying special attention to the frequently touched surfaces such as door handles, handrails, buttons on elevators. In addition, we'll be using a fogging system which sprays disinfectant in locations where students actually remove their mask. So for example, in the residential life restrooms, those will be fogged and then thoroughly cleaned. And another thing that we are going to have to do is increase our trash removal, because we expect that the locations where students will be dining will be, since everything will be in to-go containers, so we'll have increased trash removal throughout the campus.
Thanks, Pat. That's helpful. Obviously, we've got our experts on the building and infrastructure side here and our medical professionals. For the campus side, how are you consulting with our medical experts? What is your basis for that? How are you proceeding with that?
So we've worked with the subject matter experts throughout this entire process. We've used University Health Services as well as infection prevention at the hospital to assist us in defining our work practices, the control measures that we have in place. And then as situations arise, we'll call on them to answer specific questions as needed.
Great.
And they have been extremely helpful in guiding us through this entire process.
Well, perhaps using that as a model and transitioning back to our healthcare professionals, what is the science on safety for outside gatherings in particular? Because we know that we know when we're in buildings that we're going to be physically distanced, and we know we'll be wearing our PPE and such, but what about when we go outside? What's the science on the safety of outside gatherings?
That's a great question, and it parallels what we do inside. The most important factors remain masking, physical distancing, and hand hygiene. That even though you're outside, you need to maintain space. Now, we believe that outside you may be somewhat safer because this is a respiratory virus, and being outside gives more area for the virus to diffuse and makes exposure slightly less. But don't be fooled. We still need to use masking, we still need to use physical distancing, and we still need to keep our hands clean.
Great. What is the best science on the PPE requirements? And what in general, the question's more about what will be provided to faculty and staff. The current research on face masks versus face shields. So we've had a lot of discussion about that, I know, among the faculty. Is someone, maybe Dr. Tesini, would you mind commenting on that?
Yeah, certainly. Yeah, there's been a lot of discussion about that nationwide, really. And masking in terms of, keeping your mouth and nose covered really is the best way to prevent spread of the virus. It both contains your own secretions. So as you're talking, coughing, sneezing, the bulk of that really gets contained behind the mask, even if it's not an official PPE medical mask. So that's why any type of cloth face covering in any situation is highly recommended. It also then keeps your mouth and nose covered. So if you're around anyone else and who may be talking, coughing, sneezing, that then it's less likely for that virus to make its way to your nose and mouth. The face shield is added protection that also covers your eyes. So that's been the main utilization of the face shield is to cover your eyes. So again, that's another area of entry for the infection. So it keeps that covered and also provides an extra layer of covering over your face, but it doesn't provide that tight seal around your nose and mouth like a mask or a cloth face covering would. So that's why the cloth face coverings and masks are the current preferred method of protection if you're thinking mask versus face shield.
Right. So if you think one versus the other, you'd always choose the mask first, and then the face shield would be something you could add if you wanted to. But it sounds like that does more to protect the person wearing the mask, the face shield, than it does others, because you're protecting your eyes effectively, it sounds like.
Exactly. The mask really covering your nose and mouth provides a better two-way protection for you and those around you.
That's very helpful. What's considered to be an exposure to COVID-19?
We get our definition of an exposure to COVID-19 from the Department of Health. And what is exposure to COVID-19 is when an unprotected person is exposed to someone known to have COVID and is within 6 feet for more than 15 minutes. So let me say that one more time. An exposure to COVID-19 is when a person who doesn't have it and is unprotected is exposed to someone with COVID-19 for more than 15 minutes within 6 feet. Now, this definition is also why it's so important that we protect ourselves, and this is why we're recommending what we recommend. Masking and physical distancing, staying more than 6 feet apart, and masking. If someone is masked who has COVID-19 and someone is masked who doesn't have COVID-19, and even if they're together for more than 15 minutes, if the people remain masked, covering the nose and the mouth, no exposure is felt to occur. And when they do a tracer, you will not be felt to be at risk to develop COVID-19. So wear your masks, make sure whoever you're interacting with wears a mask, stay more than 6 feet apart, and keep your hands clean. And we should be very effective in preventing any spread of COVID-19.
It really is that simple, isn't it?
Yes, yes, it is.
Just get people to follow that process. That's we can't say that enough. I really appreciate that.
One thing I'd like to add to that, as we talk about interacting with people outside of a clinical workplace, is that cloth face coverings and even medical masks, if the users aren't really familiar with how to really properly take them on and off, the health department may still consider time around people within greater than 15 minutes within 6 feet. They may still consider that an exposure. So it's very important to maintain that distancing and limit your interactions with others. You know, walking by someone in the hallway, not an exposure, but that within 6 feet for 15 minutes.
Very helpful. Very, very helpful. Is there evidence that student and faculty cleaning is sufficient? I mean, how important is the risk from surfaces? Meaning, you know, if I take Clorox wipes or something of the sort like that into the classroom with me as a student or a faculty member and wipe down my area, how effective is that, and how important is the risk, or what is the actual risk from surfaces?
Yeah, I can answer that. And this has been, again, another area of discussion and research throughout the pandemic so far. And it's less of a source of transmission. Surfaces are less of a source of transmission than the direct interaction with others in terms of being unmasked and being close together and having the spread of respiratory secretions as you're talking, coughing. Surfaces really would require someone to cough, sneeze, or touch their nose, touch the surface, then have you come along, touch that same surface, and then touch your nose or mouth to get the infection that way. So there are more steps involved, and therefore less likely. The virus will also dry out and essentially die over time on surfaces. So the more time that elapses between the infected person and the non-infected person touching the same surface makes that even less likely. This virus is really easily killed with any of the EPA listed agents that Ms. Beaumont referred to. So these are things that anyone can use, much like you would clean and disinfect surfaces in your own home. It's important just to know how much time different products need to be sitting on the surface and in contact with the surface and the virus to kill it. And that's really the most important part to look at when you're using any of these products.
Great, thank you. What about, is there science behind indoor ventilation, open windows, fans, things of that nature from your perspective?
Well, we're learning more and more every day. You have to remember, we've only known about this virus for months. And so a lot of this is by inference. We know that it's a respiratory pathogen, COVID-19. We know that it can be in the air. And so more ventilation will diffuse and presumably reduce infectivity with less virus per square meter or foot or whatever you want to use. But once again, I don't want to overemphasize ventilation and de-emphasize masking. A choice between ventilation and masking, I'll take the mask every time. That if we mask ourselves, we protect ourselves. If we can lower the infectivity by ventilation in case you have to take your mask off or something of that sort, we certainly should do that. But don't forget, what's most important is the mask.
Great. So transitioning to ventilation, maybe we'll go back to the facility side of the house. To what extent has air circulation and ventilation been addressed in offices and classrooms?
So we've taken a comprehensive look at all of our buildings across all of our campuses. Just to put it in perspective, we have well over 100 buildings built at different times, different ventilation systems. Some have full air handling systems, some just have operable windows. So a great variety of situations we looked at. We looked at and assessed them all against the CDC guidance that's been issued. We focused on increasing fresh air whenever possible and outside air, which is part of the CDC guidance. We also looked at increasing our filtration to at least a MERV 13 where that was possible. And again, in accordance with CDC. And then one additional step we did, we worked with each of the different colleges to ensure when we made changes. One of our challenges was we do a lot of research here, and we wanted to make sure that any of the changes we're making to ventilation doesn't negatively impact any of the ongoing research. So we didn't want to compromise that. So all of that's been taken into account as part of the ventilation assessments that have been conducted thus far.
That's great. That's great. And where can individuals find information on air exchange in the building that we frequent or work in? Is there a place that if I'm in a building frequently, I can get a perspective on what the circulation or filtration is like in that building?
So we provided that to each of the colleges. So the deans and the operations departments at each of the colleges will have that information available. And then they could follow up with us if there's any specific areas we want to drill down into or look at further.
That's great. Have we made any updates to the air filtration and exchange methods, particularly in rooms with no windows?
So as Mike discussed previously, we're working to improve the dilutional ventilation and any means that we have for mechanically increasing the airflow. We have done that. We are working to increase the outside air volume as much as possible. As Mike talked about, we're changing to MERV 13 filters, which is a more dense filter, which captures more particles. where that's possible, we have to maintain the airflow, so there's a little bit of a balance there between those two. Another thing that we're doing is running the HVAC systems 2 hours before the start or opening of the building, and then 2 hours after the close of the building, so to increase the dilutional ventilation throughout the building. I think that covers it. Thanks.
Yeah, thanks, Pat. That's very helpful. What length of time can students be expected to be safe to stay in one room? I mean, that's assuming obviously that they're physically distanced by more than 6 feet, that they're wearing their masks. What would be a safe amount of time to be in one particular room?
So, as our doctors have pointed out, the science is evolving on this, and I'm not sure I'm equipped to say what's a safe time frame. What I can say, though, is that the rooms have all been evaluated, as we said, against CDC guidance. We've added fresh air where we can. And just to give you a couple of examples of that and the impact of that in comparison to other environments. So we've taken box fans in rooms that just have a window that opens, they don't have any other outside air. And by putting that in, and we've measured the velocity of the airflow that comes into the room, and we're able then to calculate air changes per hour. So in a typical classroom, we're achieving 7.5 air changes an hour. That's more air changes than you would see in a typical ICU room in a hospital. In a residential housing dorm room where people are sleeping, we could achieve up to 36 air changes an hour. That's double almost what you'd see in an operating room in a hospital. So we're bringing significant amounts of air in just by simple things like adding a fan to the window.
That's great. It's really good to hear that. I think some of the questions around air circulation and some of the closed rooms that don't have windows relate to practice studios, areas where music students might practice, and they typically are closed environments. What length of time would you recommend for a student to be safe in a practice room, for example?
So again, we don't have specific information on each individual room, but we are looking at those in coordination with the colleges. And where we identify rooms that we maybe cannot provide additional ventilation to, we're looking at, are there alternative sites where they can go to practice? So that's all we could do at this time.
Okay. I had a question that came in asking whether ultraviolet or HEPA filtration of the air would be useful to add to the rooms.
So we are looking at ways to improve our air systems as guidance is changing, but currently our focus is on air volume and increasing the fresh air into the spaces. As we move on, we will look at the HEPA filtration systems. The ultraviolet, I think Mike would want to speak to the whether the benefits of the ultraviolet system are worthwhile.
We've used ultraviolet, particularly in fan coil units, other things to keep them clean, but ultraviolet has some limitations on air itself because it takes contact time to work, and air is dynamic and moving rapidly across the surface. So we are always looking at those things. As Pat mentioned, we've moved to MERV 13. HEPA is even more dense than MERV 13, so that restricts even more airflow through. So we have to balance these each time.
On the cleaning side, there have been a number of questions about how classrooms, labs, and other instructional areas will get cleaned between classes, or how often will they be cleaned? What is our expectation?
So first off, prior to the start of class, every single day, our environmental service workers will be doing a deep clean of all classrooms. Between classes, we're going to request that students and faculty have cleans. Will help with and assist with the cleaning. This would be similar to whenever you're entering a retail space and there's cleaning supplies and you clean your own cart. We'll have cleaning supplies available at every entry, and students and faculty will be able to clean the area that they're sitting in or working in for that. But then we will do an additional deep clean afterwards, but we can't be going in between every class. That's just really not feasible.
Understood. Turnover time is pretty quick for some of those classes.
Correct.
Can we post a checklist in the hallways outside of classrooms so individuals know what has been done and when the last cleaning took place?
Environmental services will be tracking all of the disinfection protocol and when they are actually performing that work. It will be held in the supervisor's office. So those records will be made available to anyone who would like to see them at any time.
Okay. And you mentioned this, I think, is that in terms of cleaning supplies and sanitizer stations, they're going to be provided and accessible at the classrooms. There's a question about how often they will be checked or filled to make sure that there's a steady supply.
Sure. So the disinfecting wipes will be provided at each classroom and then refilled every morning as they do the disinfection during the, for the classroom. Then the departments will be provided sanitizing wipes to refill during the day. So they're available at all times. And if required, someone could always put in a service call to the 34567 number and we can refill those as needed as well.
There was a question, we use a fair bit of AV equipment when we're teaching in the classroom, and there was a question about microphones and other fixed or portable AV equipment in lecture halls. How can they be effectively and safely cleaned, and who does that?
So in events management is ensuring that the supplies that we're using, the proper disinfecting products are being used for the AV equipment, so they will let us know what products we should provide, and then facilities will provide those supplies, so the wipes for the stations, and then the professors will be required to disinfect before and then after they use it. And then we will also refill the products during the morning.
You might need to leave a checklist for them when they come in to remind people, it's a new world.
Yeah.
Sure. Suspected or confirmed cases. I guess this is a question for the group as a whole. What will happen when a student tests positive, both for students and for the roommate and the rest of the community?
I'll start with that one. Certainly anyone who tests positive is going to be evaluated by our University Health Service to make sure that they're getting the medical care they need. Most people with COVID have mild symptoms and are treated symptomatically at home. But if one of our students tests positive, that student will need to be isolated. And generally the isolation occurs for 10 to 14 days. And there's certain criteria for releasing persons with COVID from isolation. And that's when they become no longer infective, which is usually 10 to 14 days. A tracer is done for any patient or any person who turns positive for COVID. And that tracer is done between Department of Health and UHS. And they will look for anyone who has been exposed. And that gets back to the definition I spoke about earlier in this town hall. For any person who we know has COVID, we look back for 24 to 48 hours before they got sick till the point that we knew they had COVID. And we look for anyone who's been within 6 feet for more than 15 minutes unprotected. Those persons are felt to be exposed and at risk to develop COVID for the next 2 weeks. They're placed in what we call quarantine. The difference between isolation and quarantine is whether you have the disease or not. If you have the disease, you're isolated. If you're at risk to get the disease because you've been exposed, that's quarantine. And you're quarantined for 2 weeks. And the reason 2 weeks is chosen is that we know from exposure, you can turn positive for COVID for up to 2 weeks. Now, we get a lot of questions. Anybody who's exposed, why don't we just test them and then we don't have to quarantine them? Well, if you test someone after they've been exposed, that just means they don't have the disease that day you tested them if the test comes back negative. They could turn positive any day from day 5 to day 14, so you'd have to test them for 9 straight days. And by the end of 14 days, you would know they don't have it anyway. So we simply quarantine people, check them for symptoms daily. If they develop symptoms, we test them. But if they don't get symptoms, at the end of 14 days, they're released from quarantine.
That makes sense. And that kind of ties into another question that was asked by a group was, what happens if we test a symptomatic student and it comes back negative? Of course, you don't know you know if they have expressed symptoms, but we have a negative test. Or an asymptomatic student who maybe comes back positive. The question is really, should these individuals be quarantined? Is testing repeated? What's the process for?
You know, that's a great question because a lot of viruses circulate amongst people during especially the winter months. Most of the time, believe it or not, it's not COVID. There's plenty of other viral illnesses that mimic COVID that we will see and be concerned that someone has COVID. Our testing is very good, and this is where the RT-PCR and the highly sensitive test is used. And if we get a test that's negative, generally we don't continue to isolate someone. However, there is medical evaluation that goes on, and there are times where we're so suspicious based on other symptoms someone's having that they have COVID that we will isolate someone and retest them. Asymptomatic people who test positive certainly have to be isolated. We know that even asymptomatic patients or people can spread virus. And this is why it's so important that we continue masking and social distancing, physical distancing, and using hand hygiene, because we found from testing about 1% of our population is asymptomatically positive for COVID at any given time.
I guess, you know, this wasn't on my list of questions, but it does make me think when I was, there'll obviously be overlap between the flu season and our issues with COVID, and many of the symptoms look similar. And so it's my understanding we're going to try to get access to vaccines here early for making sure students have an opportunity to have a flu shot, which would hopefully, if the vaccine's effective, help at least minimize spread of flu on campus. Because I guess if a student contracts the flu, I mean, it's different from COVID, but it's still probably best that they stay home and get well, is the point.
Yeah, I mean, that's a great point. And we are going to be encouraging the flu vaccine like we are every year, but this year will be even more important for the reasons you talk about. But for a lot of these infectious diseases, whether it's COVID or not, probably a good idea to stay home until you're better. Although once you're better from the common cold, usually only takes a couple days, then you can come back and get back to class, et cetera, of course, with your mask on, everything else, if you test negative to COVID.
So I'm going to toss out a pretty tough question that came in, which is, what is the threshold of cases that would cause us to shut down and send students home as we did in March?
Yeah, this is a very, very complicated question. And there are a lot of different people who have input. The government, for one, like they did earlier, could force institutions to close down based on what they're seeing, not only at the school, but in the area, in the state, or in the country. That's one factor. The other factors we have to look at above and beyond just the university is what's happening at the medical center. Are we able to care for more people if they get sick? And then, of course, what's happening at the university. And I don't think we can come up with one exact number that tells us that if X% of students are either infected or requiring quarantine, that we would shut down. But we would have constant conversations, as I said, with the Department of Health, with our RRHS colleagues, and with the university, UHS, and administration to decide, you know, what's best for our students, faculty, et cetera.
Understood. And there can be different kinds of shutdown, at least with respect to the campus. I mean, we could go fully online, and the students could remain on campus, it could be that it's, you know, safer to keep them here than to have a large number of people coming into the community to help bring students home. So I guess there are options, to your point.
Exactly right. It's complicated.
Yeah. In terms of the distancing and student conduct and PPE and such, how's PPE going to be distributed? And is the university providing face masks, or, you know, and how many are we providing per student? What's going to be the availability of that? Maybe Pat or Mike, you want to address that one?
Sure. So the university has purchased reusable masks with logos. We have them for University of Rochester, Eastman School of Music, as well as the Memorial Art Gallery. Each have their own logos on them. They will be distributed, and there will be one reusable mask will be issued to all students and faculty. Additionally, they'll have procedural masks located for free that can be handed out throughout different locations around all campuses. That's in the event somebody forgot their mask that day, or their mask gets torn or damaged in some way that they can't wear it. So they will be able to get another free mask for that day. We'll also have additional logoed masks for sale at the bookstore, and students and faculty obviously are free to bring in their own masks as they like as well.
So,
And I would just add in, you know, initially when we went to universal masking in the medical center, people were concerned about reusing masks, but we've been reusing surgical masks safely for up to 7 days unless they get soiled or otherwise affected. So that's the standard that we're using that's been highly effective. I don't want people to feel like they need a new mask every day in order to be safe.
that's great. It's very helpful. How's the university going to address students that ignore social distancing rules or don't wear their face masks? I mean, who's going to monitor the students' adherence to masks and social distancing and protocols and such?
So the students will be required to sign a code of conduct that requires that they follow the physical distancing and masking guidelines. And then it's the responsibility of all University of Rochester employees to insist that we ensure we adhere to the mask and physical distancing guidelines. So every student, faculty, and staff member, it's our responsibility to make sure that we're all protecting each other. It's easy to forget your mask, so we have to make sure that we participate in that review and monitoring, and let people know if they're not wearing their mask, they need to put it on.
And Pat, I think that's a great message, because I'll tell you, in the medical center, we have the same issue. We're very good at masking and social distancing, but we're human beings and we forget, and we look at it as reminding each other. But we all have to take responsibility. We can't, it's not one person's job, and there's no way leadership or administration can force this to happen. We as a community have to hold each other up and remind each other, and that's the only way this is going to work.
I think it is a really good point. I mean, it is a social contract, and I think, you know, it's even if you're less worried about your own health, you can look at it from the perspective of taking care of other people. I mean, your professors and your fellow colleagues and others who are susceptible, even you want to be masked to take care of others, not just yourself. It's a community responsibility. So, and I think if we have a social contract among us, then we're all responsible. How would you ensure that everyone who enters the university facilities has completed the Dr. Chatbot testing prior to entering the spaces?
So each department is required to monitor their own staff, ensuring that they complete the Dr. Chatbot testing each day. I understand that they are currently piloting a reporting program and hope to have it available soon so that we can monitor. But there is, at this point, you have to be responsible for checking with your department and your staff.
And in particular, you know, some of our buildings are card accessible, but some are key accessible. So some have to remain open. So in a sense, it is the responsibility of the individual to basically follow the Dr. Chatbot and to respond appropriately.
Right.
And I guess the last question I have, and I feel like, you know, Dr. Apostolakos answered this probably earlier, but I'm going to ask it again just so we're consistent on this. When are masks needed outdoors? What will our procedures be for community members in transit outdoors, or if someone wants to go out for a run or exercise or do something like that?
So masks, as the doctor earlier stated, masks are required in all common area spaces where we can't maintain physical distancing, and that includes outdoor spaces. So that being said, we do encourage people to go outside. There is opportunity to be alone outside, away from an area, other people. that you may be able to take off a mask, especially if dining areas, eating, where you may be able to spread out, and we're looking at that to create more physical distancing. And I think one of the things students and faculty returning to campus will be pleasantly surprised with. The university has invested significantly in adding a lot of outdoor furniture, additional outdoor spaces to encourage people to get outside and to really take advantage of the beautiful campus that's available to everyone.
Yes, unfortunately, when our students are returning, the weather here is very amenable to some outdoor activities. So it's a good thing. Well, that kind of summarizes the questions that I had that were collected. Any parting comments from the group?
I guess I'd just like to say that we've learned a lot over the last 4 months, and I'm very confident we can reopen safely. I'm very confident we can keep faculty and students very safe if we just remember, stay masked, stay physically distanced, and keep your hands clean. If we do that together, if we remind each other, we can reopen safely and have very few, if any, transmissions of COVID on campus.
It really is that simple. And, you know, I would like to think that our entire society could do that as well. But the good news is that on a campus like ours, we kind of get to define that society, and those are going to be the social contracts that we all sign to be part of the community. And if we adhere to that social contract, we're all going to be safe. So wear the mask, physically distance from each other at least 6 feet, and wash your hands. I think with that we can close, and I can thank the panelists today. This has been incredibly helpful. Hopefully it will put to rest some of the questions that many have raised, and stay safe, stay healthy, and have a great day.
Thank you.
Thank you.
Thank you.